All right. Can someone in the back of the room just give me a thumbs up if it sounds okay? Oh, lots of thumbs up. So we're going to go ahead and get started. You guys are welcome to keep eating and help yourself to any more dinner and dessert while I get started. But I just want to welcome you all and introduce myself. My name is Lauren Oshman. I'm the program director for the Michigan Collaborative for Type 2 Diabetes. I'm a family doc. As you all know, we've been here now for 3 years. We've done regional meetings, and so it's lovely to see some of the same relationships and start to feel like I know all of you. My practice is out in Chelsea, and then the rest of our team with MCT2D is at the back table. You met Lefa and some of our team members at check-in. Please feel free to kind of meet us and say hi. So we know we made you come here, but I know everyone had a really busy day, and I just really, really appreciate you spending time with us, and so we want to make this as high yield as possible. So I want to jump into the plan for this evening. For the first part of the evening, we're going to do some program updates. We are going to go through some information about this year's value-based reimbursement and quality improvement goals. We'll take a break. We have invited Dr. Kim Yu, who is an internationally known speaker on physician burnout and well-being, and she's going to do a presentation for us. And then we're going to announce some very exciting news from Blue Cross about a patient empowerment toolkit, and then give you some more updates before you go home. I just think these regional meetings are so nice for me to appreciate our team and you all and all of the work that we've done. Sometimes it feels like we don't appreciate and take time to honor all of the hard work that's been done. And so since we met last time, we've done 5 different learning community events. Those are our lunchtime events. We have taken some of the best work that we've done as a collaborative, and we try to present that to an external audience. So we went to the American Diabetes Association and presented 2 posters there. We have launched a collaboration with a low-carb focused restaurant that you will hear about. We keep updating our resources based on feedback from you so they can be more useful to your patients. Today we launched our revamped website. We're going to give you a little bit of a walkthrough. And then every spring we host a collaborative-wide leadership meeting that's mostly provider organization focused. And we just had a very in-depth talk about social determinants of health at that meeting, and we will continue that work through over the next year. Our new VBR year launches in September, and we'll talk a little bit about how we're transitioning our VBR from learning to quality improvement, and then we've started disseminating quarterly reports to your POs so that we just get in the habit of seeing our quality improvement data. So this is just some early success, right? So we have our data dashboard. We have data that we're pulling from our Blue Cross Blue Shield and BCN patients. And the whole goal of MCT2D is to be all patient, all payer. So by the time I see you next year, my hope is we have data from all of our patients with Medicare, private insurance, Blue Cross Blue Shield, and eventually Medicaid. And that will really allow us to look at things like health disparities, where if you don't have Medicaid data, it's really hard to tell that story. Even yet, we didn't ask anyone to set a goal for improvement, and this is our region-specific data for our area, and all of you here, you can see that for continuous glucose monitoring, pretty flat line when you look at the aqua down at the bottom for all patients. But if you look at patients who have prescriptions for insulin, and this is most reliably where people have coverage for CGMs, you can see a significant improvement since we began our collaborative. And so I think that's like quite remarkable. Overlaid here are prescriptions for sulfonylureas and insulin. So not only are we utilizing CGMs, but we can appreciate that there's some trend here that this may actually go together, be associated with decreased insulin use and sulfonylurea use. So similarly, just looking at our region and how we've been doing with prescribing guideline-directed medication therapy, we can see increases in blue up here, either in SGLT or GLP. I would say it looks to me like GLP prescribing has gone up more than SGLT2 prescribing, but both have increased. We can see sulfonylurea prescribing decreasing and insulin decreasing. So One of the cool things we'll be trying to do is to look at practices who are not part of our collaborative to see if we are making the difference or if this is just a trend across healthcare. And then the last thing that I want to tell you is that this data is only fresh through May, and just this week we updated our data through July. So if you go into the dashboard today and you pull a patient list, it'll be data through last A1C in July, last laboratory values in July. So I just really want to appreciate all of the hard work that you've been doing with learning about updates in diabetes and implementing them in your practice. We are always happy to meet with you and go through use of the data dashboard, how you can use it to see trends, pull patient reports. If you have any interest in that, just let us know. So I want to go through some updates about medications and CGM, and I'm going to bring up some of our other team members to do that, and then we'll segue into quality improvement. We had that first, but it involved talking and writing, and you're all eating, so thanks to Jackie for changing the order. I looked around and said, this is not going to be a good time for people to talk and eat. So just, one of the things that we know you've appreciated about these meetings are keeping up to date about kind of the newest and latest things in diabetes care. So did anyone see this in news reporting that semaglutide is associated with ileus? So like the same day this came out, I had a patient hospitalized for ileus. And so I was messaging with one of our endocrinologists and the surgeon, like, did I do something wrong? And not for that patient. And so what we know is that there's no relationship, there's no causation, but certainly some sort of association, and nothing is changing for me as I'm counseling my patients. I've had, since using these medications, several patients develop severe abdominal pain. You stop the medication, it gets better. I just always warn patients about the possibility that they're gonna have GI upset, and if that's severe, they need to go to the ER. We have no idea if this is, they didn't compare this to a group that didn't have semaglutide, and so I think this is just something to be aware of. As always, if patients bring it up to you, now you've heard about it. GLP shortages, raise your hand if you're still having GLP shortages. Which ones? All of them. Tirzepatide. Is anyone still seeing shortages of Trulicity? So I feel like it's gotten a little bit better. Still, certainly Ozempic, semaglutide, and tirzepatide. Just to remind you, we have this tool on our website that gives you dose conversion. I feel like a year ago no one was comfortable with this, and now we all know how to dose convert because of the shortages of these drugs. So just tools that we've made to help you along the way. And then the last thing that I wanted to mention before turning it over to Heidi is just shared information about how CMS is grading us for medication utilization. So the Advantage programs have a star rating system, and they're really looking at adherence to diabetes medication as a key and core measure for primary care practices. And so what they're looking at is adherence to any diabetes medication. And when a patient can't afford their medication, that negatively affects our rating, or your rating, your PO's rating. And so what I want to communicate to patients is just that if you're having trouble affording your medicine or you have a side effect, let me know. I don't want to see a gap between a GLP they didn't fill anymore. I want to replace that with an affordable medication or a medication that they're not having side effects from. Along with that, we started really talking about medications and updates, new medications that I hadn't used before, SGLTs and GLPs. Well, now we're going to have GLP GIPs and maybe a GLP GIP glucagon triagonist. We're going to have an SGLT 1 and 2. So the name is getting too long. We're going to change it. Now our initiative is going to be aligning medication prescribing with guideline-directed therapy or medication guideline-directed care. And we're used to this terminology in heart failure and other chronic diseases. So instead of talking about prescribing GLPs and SGLTs, you're going to hear us talking about guideline-directed medication therapy. What this means is not only prescribing newer medications when they're appropriate, but also thinking about deprescribing of insulin. So as we reflected on what we want our goals to be this year, we thought that this broader language would be more appropriate. I'm going to turn it over to Heidi to reintroduce Frank the cat.
All right. So before we get to Frank the cat, how many people have heard of Brenzavi? Raise your hands. Oh, 2, I think. That's fantastic. More than last night. So for the rest of you, this is a new SGLT2 that was approved in January. Dose is 20 milligrams a day. It can be given down to a GFR of 30 and above. Couple of things, though, that we want to point out about this. Number one, how do we get this drug? As of January, it was supposed to be available via Cost Plus Pharmacy. Has anybody heard of that? Elise, yes. So this is Mark Cuban's pharmacy, also the owner of the Denver Mavericks. So he's gotten into pharmacy. He collaborated with a friend that's a physician. And so their mission is to provide medications at lower cost. So patients can get this drug from Cost Plus for $47.85 plus shipping and handling. Things that we need to know about. It's been proven non-inferior in cardiovascular trials, so no difference there, but it's not proven better like the other SGLT2s that we have. So it does not have indications in CKD and heart failure like we see with the other SGLT2s, so Jardiance, Farxiga, and Invokana. We're not clear on insurance coverage. I do think this is supposed to be a drug for a cash-paying patient or a patient who might not be able to afford their copay and they have insurance. I assigned this to my student to call around to the pharmacies to see what this is, because I hadn't heard about it. The pharmacies had it on their distributor list, but they've never ordered it. They're not sure if they actually can get it, and they've yet to see a prescription. I called every chain and independent pharmacy in Washtenaw County. So just throwing it out there, it's there. And who might you use this in? You have a patient who maybe is already on a GLP, and they can't afford their SGLT2, so maybe we try to find this drug, because we're still getting cardiovascular protection from that GLP, but then we're using a drug that we're not sure about in terms of protection with cardiovascular. The other thing I wanted to point out is just to keep in mind, in January of 2026, the Inflation Reduction Act, I think that was passed in 2022, is going into effect. So there's a list of the most common top 10 drugs in seniors, and so they're going to be able to negotiate prices. So Farxiga and Jardiance are on that list, so we will see reduced prices for those brand name drugs, but unfortunately we have 2 years to wait on that. Frank the Cat is back because, just a fun little fact, Bexagliflozin was actually first approved a month prior to humans in cats. So it is the first oral medication for diabetes in cats. So if any of you are cat lovers out there, I thought I'd point that out. Finally, we're going to talk about this decision aid update, but I just want to point out this, let me see here. In this area, you'll see the various SGLT2s that do have those proven indications for the other conditions. So HFpEF, HFrEF, and then CKD. All right, so switching a little bit of gears to obesity, and then we're going to get back to diabetes. Just wanted to make you all aware that Qsymia now is no longer covered on Medicaid. So there's no amount of prior authorizations that you can do to get this covered. They've stopped participating in this Keep On program, and it's not just specific to Michigan. This is nationwide. So now we have lost that ability. So you'll see we've updated our coverage guide to now say not covered, unfortunately, for and Contrave. Oh, thank you, Jonathan. October 3rd, Dr. Gabison saying Contrave is no longer covered either. So this is quite unfortunate. So now we get to, let's switch gears to some better news. The good news is now Mounjaro is covered as a preferred med at a Medicare Advantage HAP plan. So you do now have that as an option as a preferred med. More good news. So Aetna commercial, I was floored when I heard this, and I just wish more payers could adopt this. We not only do not have to send it to DME anymore for Aetna commercial CGMs, we can send it direct to the pharmacy, but here's the coolest part. They have the least restrictive criteria for coverage of a CGM that I've ever seen. So you can simply say my patient has a diagnosis of type 2 diabetes, or you can document that this is your recommendation. They need a CGM. They should get a CGM, and it goes through. So amazing. We'll keep trying to push other payers to have such open-mindedness with this type of coverage. In terms of Blue Cross Complete, so this is a managed care plan with Medicaid, the big update here is that the G7, Dexcom G7, is now covered. So before it used to be just the G6, but we do have the G7 now, so just know that you have options. I have patients actually that prefer G6 over G7, so you do have the options to use either. All right, this is just a reminder, the QR code's here. How many of you took advantage of our clinician-free sensor wear so you understand kind of the life of your patient? Excellent. So we just wanted to let you know we've extended this for kind of infinity for now. And so please pass this along to your colleagues in your clinic, other physicians, other nurses, if you have a pharmacist, physician assistants. They can all have this opportunity to get a sensor. So just wanted to be sure that you know about it, and just a great way for us to continue to support our patients, because we'll have an idea of what it's like. Some updated tools. So we heard from you. You guys gave us feedback on our insurance coverage worksheet that it wasn't exactly directed at the patient. So we've completely revamped this, put it more in the voice of the patient. But again, the concept here is that you have a worksheet so your patients can call the insurance one time, and you can check at the top what you want them to call about, whether it's either GLPs, SGLT2s, or CGMs. And then it lists all the questions that they need to ask. So then hopefully they can either turn that back into you, they can take a picture of it and send it to you on the portal, and then we can make an informed decision. So I do hope you find that helpful. We as a team are constantly updating our coverage guides, so almost quarterly, if not more frequent, so those are always up to date for you. And then the medication decision guide that I showed with Frank the cat, something that I've worked really hard and I'm proud of. I really tried to use the ADA guidelines, but try to put it on one page for you. So not trying to say, well, here's a pretty little chart, but if you want this, how about you go read this footnote, and then maybe you'll come to the decision. So there are footnotes on mine, but it's really kind of extra information where you can look at the chart and kind of figure out some options. So I do hope that is helpful. And we have new tools. So we have a CGM kind of general information about the two different ones, so Dexcom and Abbott. And so this is meant to be a handout for your patients. Maybe you're saying, hey, I think a CGM would be great for you. Here's some options. Here's the patient insurance worksheet, and take this and see which one's covered. And then the other thing I'm also proud of is in my PharmD group that meets quarterly, we've heard raving reviews of Parachute. How many of you use Parachute? Lucky, lucky. So, and so this is just a kind of a tutorial to help you if you're able to use Parachute. It's free, but different organizations from a security standpoint have different rules about their employees using it. So at Michigan Medicine, I'm working right now to try to get appointments with the higher ups to see if we can get approval to use this, because per my PharmD colleagues, saves immense amount of time. All right, so closing up here, just wanted to share a new dot phrase, so .cgm insurance I added, and this is just a nice line that you can put in your note. I'm sharing it with my clinic to kind of try to address some of the DME insurance requirements, so stating that a patient's compliant with their meds. What are their meds? Is it basal insulin? Is it basal prandial? And then the other big important thing is you have to have documentation that you're reviewing their CGM data. So I put it in a drop-down list. You can say, yep, I checked, I reviewed that CGM data, and then it's there. So hopefully we can get a little smoother coverage for our patients. 2 more slides to go. So just wanted to, again, bring your awareness to our smart phrase library, dot phrase, sorry. And so this is a QR code that brings you to our library. You can search by EMR. You can search by topic, so CGM. Within those topics, maybe you want CGM education. Maybe you want documentation help. And so that's all there. Since we launched this in the spring, we've had 11 new dot phrases added. So please, please keep sharing. This is hopefully helping us all become more efficient. And then finally, this is how you would go about that in terms of sharing. So this is the QR code in the website to log in, share your phrase with us, give it a name, and then we can all maybe use that. So with that, I'm going to turn it over to Lauren.
Thank you so much, Heidi. we have a couple more updates to give you at the end of the day, but I just wanted to switch to allow you some time to share, discuss it, and learn from each other. The benefit of these collaborative regional meetings is that we get a chance to join together in person and create that community that can help us get back best practices to everyone. So I'm going to walk you through what we have planned for our next year in terms of quality improvement. Our VBR measures, talk a little bit about how I think about quality improvement, how I was trained in QI. We're going to have an activity of brainstorming, and then we'll talk about next steps. Our value-based reimbursement year here starts in September, and so it's really just starting now. This year, we are focusing value-based reimbursement for every provider organization on one of the 3 pillars, and so that could be medication prescribing, use of CGMs, or lower carbohydrate diets. And really the idea with QI is that we can't boil the ocean all at once. We just want to pick one thing and improve, and then at the end of the year at our spring regional meetings, we'll have an opportunity to learn what each of our POs did and then share that and adopt changes across the collaborative. And so, you know, one of the things that we have been asked is, do we have to improve GLPs by a certain amount? What's appropriate? What's the target? And the goal is to set an aim and to make some changes and share the lessons learned. The goal at this point is not to hit a specific target, although in QI it's important to have a direction we're going, a target to try to hit. Sorry. So for those of you where your provider organization has chosen to work on CGMs or medication, your provider organization has probably already started convening a meeting. You may be having that coming up soon, and then they will get your ideas and then submit a PO level goal for medications or CGMs, depending on which one. Once we've reviewed that, we'll ask them to submit some ideas for process changes at the practice level, and then we'll be just sharing best practices across the year and helping troubleshoot to make sure that you're able to execute those change ideas. Finally, we're going to follow up and review the data and determine if progress has been made, and then in June we will close out that calendar year for VBR and then give everyone credit and money for participating. For low-carb diet, I think the tricky thing is that there's really no data in our dashboard that I can use to demonstrate the diet that a patient is adhering to. So other than like manually looking through your notes, and I typically don't write in my notes what the patient's diet plan is, we're still at a point that we're needing that data from patients. So one of the things that we're going to do is have those practices obtain patient-reported outcomes. So part of that group is going to be sending flyers home with patients, and they're going to be filling out a summary of their experience with nutrition education in the practice. We'll be looking at some improvement goals then. At the end, patients who've gotten that improvement, that advice, or whatever we decide to improve low-carb diet counseling will then fill out some more patient-reported outcome measures. So when I think about teaching quality improvement, like the very basics that I focus on are the ideas from the Institute for Healthcare Improvement. I did my QI coach training there, and this idea of the model for improvement. And it really starts with saying, what are we trying to accomplish? And not generally like making the world a better place, but specifically enough so that we will know if improvement has been made. If I want to run a marathon in a minute 59, I haven't ever run a marathon. That's never going to happen. But if I want to run a 5K in less than 40 minutes, that's a really specific goal. It's not just like, I'd like to get better at running. And so we want to have an aim that's time-specific and measurable and really defines the population of patients that we're focusing on. We need to establish a measure so that we have some way to measure if a change was improvement. I think it's true that not all that is important can be measured, but if we don't measure it, then it's really hard to get our organizations and the powers that be in healthcare to support us in making change. And then we need to select changes. We need to be really specific in thinking what specifically about our practice or our process or our patients can we change to get there. And then we need to test those changes in PDSA cycles. And so this is really how we'll be teaching the provider organizations to implement QI. So you should find your PO here. Hopefully you already know which group you're in, but for the next part of the exercise, we're going to have you utilize one of the handouts that's at your table, and we're going to start by writing in medication, CGM, or low carb as your aim. So I'd like you to go ahead and open your folders. I'm sorry about the lighting in here. We could turn on these lights, but I think you should just pretend you're taking a class in a fancy restaurant. you can use your phone for extra light if you need to. You're going to find a document that looks like this. And I'd like you to just go ahead and take that out as I go over these last few slides. So when we think about setting an aim statement, this is really the same idea as a SMART goal. We want to talk about specifically what we're trying to improve. We want to know where the process begins and ends and why it's important. And so my particular PO is working on CGM prescribing. I'm making this up because I haven't talked to them yet, but let's imagine I wanted to focus on patients with an A1C over 8% who are prescribed basal bolus insulin. That tells me really specifically what my population is. And then I might say the process begins with identifying patients with these criteria and ends at the point that I'm offering them the CGM. They either accept or decline that offer. And by working on this process, it's important because we can improve their glycemic control, and it offers us the opportunity to maybe decrease their insulin and offer them a low-carb diet, not just increase their insulin. The next thing I'm going to have you do is this brainstorming activity, which is filling out a driver diagram. If you remember back to our spring regional meetings, we did an exercise that was a chutes and ladders type game to talk about prior authorization. This is really a different version of a QI tool that is a current process map. This is a little bit different, and a driver diagram is just a visual tool to show our theory about what might drive change. Typically, we think about primary drivers as the most important influencers on the aim, and there may be just 2 to 5 of them. We want to keep it minimal. And then the secondary drivers, there may be many of them that influence the primary drivers. As we think about those drivers, then they help us think of ideas of tests of change. So each one of those drivers, we might have an idea for the way that we could test that in our practices. And so as we think about drivers and how we would test them, then we think about, okay, how would I measure that? If I am trying to improve CGM by, educating my patients, how am I going to measure that education PDSA cycle? So here's just an example, and then I'll tell you the instructions. The first thing that I did was write my aim statement on. I want to optimize CGM utilization for patients with type 2 diabetes using insulin. You don't have to be that specific. Just focus on CGM medications or low-carb diet. And then the drivers that I selected were patient identification, that I needed I have a hard time identifying which patients in my practice might be a good candidate for a CGM. Under patient education, I feel that sometimes when I talk to patients, they're not as excited about it as I am. I want a way to explain to them how this would be beneficial for their diabetes control. And then under primary care team processes, not all of the doctors and APPs in my practices know how to use that report then to make a change, to either decrease insulin, give dietary advice, et cetera. And so I just gave you a couple of ideas for change that I thought of. Maybe I'm going to make a list of patients with these criteria and then have my staff reach out to offer visits to them. And so what I'd like you to do now, in preparation for the fact that you're going to be doing this and sharing your best ideas with your provider organization, is to take about 5 minutes, and I'd like you to brainstorm at least 1 and up to 4, because maybe that's how many boxes there are, primary drivers, and at least 1 secondary driver that you think will drive change to reach your aim. And then try to think of at least 1 change idea or something that you could turn into a PDSA cycle and measure at your practice. Does anyone have questions about the task? All right, I'm going to set a 5-minute timer. Go ahead and get started. You can do this on your own, and then we'll take a few minutes to report out as a group. Right, this is great. I think Ann Arbor is our fastest thinking and writing region. I would like you to write something down if you don't already have at least 1 idea for a primary and secondary aim, and then go around the table and maybe everyone just talk about 1 of your secondary drivers and share 1 of these 3 questions with your group. Maybe you could share which one you think might be easy to change. Maybe you could share 1 that you think might be very difficult to change. Or maybe you could share which change you think will have the biggest impact in reaching your goal. So you can not repeat the same one the person next to you said. If they take yours, you got to think of a new one. And then I'll give you about 5 or 10 more minutes to talk. All right. I'm going to wrap us up. And Jake and I both have microphones. And I'm going to ask for some tables who feel comfortable maybe sharing what your topic was, maybe one driver and a way that you think you might test that in a PDSA cycle. Does anyone feel comfortable sharing an idea you felt was a good idea to share? I'm comfortable with silence and with calling on people. No one's making eye contact with me. Anyone at this table comfortable sharing an idea for change? All right. Round of applause, please.
Okay. I hope I did this right. All right. So my aim to improve was increasing the percentage of diabetics on either a GLP-1 or an SGLT2. I had three primary drivers, but I guess the one that I'm going to focus on is cost. And the secondary drivers is like insurance copay, like the amount the patient has to pay, and the patient's budget, like how much they feel like they can reasonably afford. And my specific idea for change, I've kind of started to do this already, but they can get coupons through the website, and that seems to be pretty helpful. And so just recently I've been able to get some patients on these meds because of that, so I'm going to keep doing that.
Thank you for being the first person to go. Is anyone else comfortable sharing maybe who's focusing on CGM or low-carb diet, an idea for change? Dr. Gavison, thank you.
One thing that we were talking about, and we were trying to figure out how to put it in your definitions, but we are quality improvement is CGM prescribing, and you know, we are working along the same lines of how you were thinking. But one of the other things that we were thinking about as a primary driver is there's a lot of pressure from our healthcare system about driving revenue, right? So financial aspect would be the primary driver, and the secondary drivers for that would be running we can get RVUs for running CGM reports every month. We can get RVUs for that. We need staffing for that, right? Would these be secondary drivers? Okay, there we go. And then that would lead to the specific idea for, we can like track this by seeing how it increases revenue.
Thank you. Very good. Round of applause. Sharing is good. Any tables in here working on low-carb diet, or is that in a different region? Right. Maybe one other table. Anyone willing to share another idea for change that you haven't heard already? Low carb. All right. Would anyone at this table mind sharing an idea for change?
So I think we were chosen to do low carb diet because we have some dietitians that work in our practices, and so it would be really helpful to have that to work on this process. So we thought that most importantly we need to have not only patient education but staff education as well, because I think that when patients have questions they need to have people who can answer their questions. We thought about doing using our dietitians for staff education as well as patient education, but also coming up with a toolkit for our patients that when they're pre-diabetic or if they're diabetic, the toolkit will have several things in it with information for them about low-carb diet. And there's a couple tools I use all the time off of the MCT2D website. One is the lower carbohydrate eating, a free starter guide for patients, and another one's called Building Your Plate. And there's actually a new one I saw that looks kind of cool. It's called the Daily and Weekly Food Log Tracker with Carb Cheat Sheet. So we could use those and teach patients how to use those to work on their process. And then I'm not sure what our endpoint would be, but maybe we could talk about lower insulin doses or better A1Cs at the end of the process.
Excellent. So just this idea of how do you create a small, right? These are all pilots. The idea that, it takes a lot to change a healthcare system, but anybody can do a pilot. We're not going to do it forever unless it works. And so for an education initiative, I might just track the number of patients who were educated or the number of patients who said they liked it to decide if we want to do it again. Or was it too difficult for the docs and did they complain? Did everyone like it? That sort of stuff. The thing is that we know that these are all evidence-based interventions. At the end of the day, we're going to see A1C improvement. In 20 years, we will see reductions in heart failure and chronic kidney disease. We're not proving that. We're just trying to find ways to implement this in our practice so we can do it more consistently with more patients. So I really appreciate you doing that. I was going to have you take a picture of your driver diagram and send it to me. You could also just give it to me unless you want to keep it. So at this point, I would say hand in your driver diagram to me, but if you want to keep it, please take a picture of it and do that now. So if you don't want to keep your driver diagram, when we get to the break, which will be in a few minutes, I'm just going to have you hand it in to the group at the back table. All right, I'm going to come back to this at the end. I want to get through the rest of the slides and send you to break. Okay, I just want to go over one more thing with an AIM statement before I let you go. So the idea that we're trying to get real specific about what we need to change, what we're going to do, how good is it going to be, by when, for whom, and the scope of the process. And so, a good AIM statement is we want the world to be a better place. We want to improve diabetes care. We want to increase CGM prescribing. An even better AIM statement is telling us exactly which patients we're going to focus on, maybe a specific % improvement goal if we have that data, and the end date. And then finally, thinking about how are we going to measure things. So there's two examples here. One is, a personal goal of mine is always to arrive on work, to work 100% of the time. I was just interviewing someone and they said, if you're early, you're on time. If you're on time, you're late. And if you're late, you forgot to show up. I love that. So my outcome measure, if I'm just trying over the course of a month to get to work on time, is the % of time I arrive punctually. My outcome, if I'm decreasing the average A1C of my population of patients with diabetes, is the A1C. But my process measure might be just like checking the A1C, because it's going to take a while to see that improvement. So a process measure is just something that I can measure quick, so we can know if something's working or not. And then a balancing measures improvement is important because maybe we do this education and then we're all running late because it takes 15 minutes to do and we can't do it in the time we're allotted. So it's important to think as we try to improve quality, is there something that we're going to make worse because of what we're trying to do? Patient cost, for example, with GLPs and SGLTs. So then we have our best ideas for change, and as a provider organization, we're going to pick just a few, the most important ones to test. And that means we're going to plan a test, we're going to implement it, we're going to look at whether it worked, and then we're going to fix it. So research is, setting a protocol in place, doing the whole thing, and then a year and a half later you get data. Quality improvement is small tests of change and making rapid improvements. So my idea was that I wanted my nurses to download CGM reports because my patients were calling in between visits and saying they had a problem with their insulin dose, and so I wanted my nurses to send that report to me. And so my PDSA cycle is going to be really small. Maybe I'm just going to teach one nurse to do this, and she's going to do it for 1 week. And maybe I'm just going to track the number of patients that she was able to do this successfully for, and whether it was able to save them a visit, and I was able to manage it over the phone. And then after that week, I'm going to decide, did this work great? Let's do it in the whole organization. It didn't work. Let's not do it again. Let's try something else, or I'm going to adapt it. I need to run the PDSA cycle again slightly differently. And so that is just a brief intro to what you're going to be doing with your provider organizations. It is now 6:49. Anyone have any questions about quality improvement that you want to raise, or other comments about the activity or exercise? Of course not. There's cake in the back of the room. Please take a break. We're going to start right again at 7, and you can take a picture of your driver diagram or hand it to me or someone in the back of the room. All right, break time, and I'll see you again in 10 minutes. All right, I'm going to introduce Dr. Yu and get us started for the second half of our presentation. Quality improvement can be difficult, and making change can certainly be stressful. And, we've been just talking about the kind of post-COVID burnout and how this really feels like chronic, our decreased staff and the stressors we have. In our office practices. And so I wanted to invite Dr. Kim Yu, who's a friend from our work in the American Academy of Family Physicians and an internationally known speaker on physician burnout and well-being, to talk to us about burnout and how to keep ourselves sane while we're trying to improve things. I also wanted to say why you're here on Zoom. It's because you're in California. And Dr. Yu has agreed to do this presentation 7 times. So we would want her to be here in person. I know she'd want to, but go ahead and take it away, Dr. Yu.
Hello, my name is Dr. Kim Yu, and I am so happy today to be bringing you Finding Joy in Practice. If you are watching this video right now, it's because I was unfortunately not able to join you in person. And so I look forward to being able to share a few pearls with you today about finding joy in practice, what burnout is, and obviously share a little bit of what makes practicing in medicine so exciting, especially in challenging times like we have now. I have many ties to Michigan, and I'm really excited to be back talking to many of you who are in Michigan right now. I used to be at the University of Michigan for 3 years doing research just prior to doing my family medicine residency, actually in diabetes, in the Department of Internal Medicine and Family Medicine at the U of M. And so it's exciting to be talking to you today about this topic, which I've really discovered has been a passion of mine for many years. So we'll talk a little bit about joy in practice, about Ikigai and what that is, and also some lessons learned in self-regulation and joy recaptured, and also talk about a game, because it's always good to have a game, right? Obviously, this is only a short introduction and not meant to solve burnout completely in healthcare, because we're going to be doing this in less than 30 minutes. And so I wanted to leave you with something memorable that you will take away and hopefully make a difference in your own personal journey. This is a little description to my why and some photographs of my family. You can see I am married and I have 2 children. This was taken a long time ago because they are now teenagers. And if you have teens like mine, they don't like having their photos taken. But this shows my love of Marvel and also Disney characters. We also love to travel, and you can see here a group of other physician women, a Facebook group I created of physician women in family medicine, and also the photograph, which is like a heart with many of us holding up house signs, is to signify the building the future with family doctors for the World Organization of Family Doctors. I know that many of you may be in multiple different specialties, different parts of healthcare, and so this talk really does apply to everyone, not just to family physicians, but to everyone that's in the clinic and who works in a practice setting, but also in hospitals and wherever you might work in healthcare. I hope this talk will resonate with you. So what does joy in practice really mean? And this was information taken from the Annals of Family Medicine, but really applies to everyone who works in a clinic setting. That joy in practice really is about having that high level of clinician work-life satisfaction, but also ensuring that we have a low level of burnout and a feeling that medical practice is fulfilling. It does not include dreading going to work each day or feeling that you really don't want to be where you're at as you're driving to work, right? And that fulfillment in practice really is tightly related to the practice environment and culture. If you have a toxic culture at work, that is not a good situation to joy in practice to everyone that works there. You want to have low administrative burden and not feel like you're drowning in administrative tasks, and the ability to form meaningful relationships with patients and provide high quality of care to those patients. And so, for many of you, you may be thinking, well, what are some of the joy stealers in your practice? These are the things that steal your joy. They take the wind out of you as soon as they happen. Is it prior authorizations, administrative burdens, or is it your EHR? Is it death by 1,000 clicks? Is it the demanding patients that you may have, or staff members or colleagues calling in, not being able to come to work? Or maybe it's all of it. Maybe share in the chat, what are some of your joy stealers, or with each other, what are some of your joy stealers in your practice? Medscape did a survey looking at what are joy stealers in practice, and this was to 13,000 physicians of 29 different specialties. And they did have slightly more men than women who filled out the survey. And you can see the predominant thing that stole joy was having too many bureaucratic tasks. So people work in charting, also lack of respect, or too many hours at work, and the rest that you can see that follow. And so think about what a joy steal is for you, and write down what it might be for you personally, and maybe for those that are around you, and see if there's any way that you can work on that particular thing for that the item that may be taking away your joy. When you think about what would help most to reduce burnout, this is also from that same survey, many found that having a more manageable schedule was definitely something that would help reduce burnout. I know some may have time scheduled to be able to do administrative work, or to actually have different activities or tasks broken up so that you're able to do administrative work compared to the clinical work at the same time. Making sure that you have increased compensation and greater respect from others, and having more control or autonomy. The Mayo Clinic also has a model where they looked at collaboration and how that reduces burnout and promotes engagement, and really having focus groups to identify local opportunities to improve care of patients and mitigate drivers of burnout. There is empowerment of physicians to develop and implement solutions to burnout, providing time and a team to achieve work, and ensuring that there is monitoring of outcomes and recognizing accomplishments and sharing best practices. If you do all of these things, they found that you could increase morale, increase teamwork, and have more satisfaction with handoffs. And in general, 50% of their work units had increased in and experience increase in satisfaction and engagement, or both of those things. And so, think about what are the things that you could do to empower the staff wherever you're working to implement solutions to burnout, and really provide not only time but a team to achieve the work. It is not the time to do what I was working in a hospital and they gave me a scarf, a woolen scarf. And I was like, well, it might keep me warm during the winter, but in 80-degree weather, it does nothing for me, and really didn't really do much to help me with burnout, right? This is not the time to be talking about you need to do yoga, or you need to come to a mandatory meeting about burnout, right? But trying to foster opportunities for collaboration is critical to being able to reduce burnout. Now, some of you may say, why do you have a picture of a mole? And this is an eastern mole. And, I thought, oh, it's kind of cute. But at the same time, it also reminds me of, have you ever been to like Dave and Buster's? They have that game where you like hit the mole with a hammer. And it can sometimes feel like that at work, right? You've got one thing that happens and you're hitting the mole, and then nothing happens and you're hitting the mole to try and, make sure that you're not having all these different things, different moles that you have to deal with on a daily basis. And so whacking the mole, or whacking the whack, as we like to say, is something that we like to really work on. And what is WAC? Well, WAC is, if anyone doesn't know, WAC is work after clinic. And so you want to whack the WAC, right? You want to make sure people don't go home with work after clinic. And so we also want to ensure not only that we whack the whack, but we want to also fill our buckets. Now, some of you may have read a book about filling your bucket. It's a great children's book. And another book that I love is The Boy, the Mole. Again, the mole. Remember the mole, the fox and the horse. And in this phrase, it says, "This storm is real, our fear is real," said the horse, "but our love is real. And in the end, love wins." And so think about, this storm, whatever storm you may be going through right now at work. And obviously, that we've been through so much with not only the pandemic, but with the demands that have increasingly been put upon us in healthcare to deliver on aims and quality measures and all the different things that we need to work on. But we know that our love is real, our love for our patients, our love for our communities, our love for each other, those that we work with. And in the end, love wins, right? To remember that. And we know that research actually shows that these feel-good relationships that we have at work, not just relationships like, oh, that's my work colleague, but that someone that actually you feel good about actually hanging out with actually increases engagement at work, performance, and retention. And so this was a study done by a group of community health centers, and they showed that if you have a buddy program at work, that can also help with increasing engagement, performance, and retention of staff. When I think of ikigai, this is a Japanese term to mean the reason for being, the reason why you get out of bed every day. And it is that intersection between what you love, what the world needs, what you can be paid for, and what you're good at. So the intersection of your passion, mission, vocation, and profession. And that there can be no greater champion for healthcare than you. Right. And, when you think about your ikigai, think and actually take time to write down what it is that you love and what it is that the world needs and what you can be paid for and what you're good at. And are you at that middle part, the ikigai, the red dot, as they say, right? Are you at your ikigai in life? Now, there were times in my life where I would say, I was doing what I loved and I was good at what I did, but I wasn't really being paid for it. Likewise, there may be some of you that maybe you're not getting paid for what you're doing, but you really don't love what you're doing. And, maybe you're not even good at what you're doing, but you are doing what the world needs, right? But is that really your ikigai? Is that what really gets you out of bed every day? So think about what it is that would get you to where your ikigai is. One day, I'll have a book about this. But in the meantime, think about ikigai and maybe draw 4 circles and put where your red dot is. So I'm going to give you a moment, a very short moment, or you can pause the video right now and draw your 4 circles. Write down what you love, what the world needs, what you can be paid for, what you're good at, and your ikigai. And get a red pencil or a red pen and mark where your red dot is. Is it in the center at your ikigai, or where is it? And what do you need to do to get to where you need to go? So I'll give you a few moments to put that in. So here's the description of the exercise on a piece of paper. You write your mission, your reason for being, what you're good at, what your vision is, your red spot, where are you, and what steps you need to take to get to your red spot. Again, if you need to take time to pause this video, go ahead and do so. I think it's also important as we move forward to think about connecting through collaboration. Obviously, the work that you're doing with MCT2D the Michigan Collaborative for Type 2 Diabetes is critical. And by formulating the work that you're doing each and every day, it really can help you in fostering that sense of community and the ability to be able to do the hard work of performance improvement and the quality work that you need to do in MCT2D. So I want to thank again the work of Dr. Ashman and many of the team members that you see here for the work that you are doing, and also for the work that you're doing in your clinic with your staff every single day. When you're actually going through stressful times, it's important to think of self-regulation. Self-regulation really is the ability to immediately shift from sympathetic to parasympathetic dominance, especially when you perceive threat. So, for example, if you're sitting in a room, I'm sitting in California right now in my home, right? I could say that I feel pretty safe while I sit here. But then again, I live in California and not in Michigan, although I did live in Michigan for 23 years. And I must say that when I was in Michigan, sitting in my room at home, I would probably feel pretty safe. I wouldn't be worried that there may be an earthquake or there may be a fire, as we have here in California. So I want you to think back to a particularly stressful conversation you might have had either with a family member or staff member. Maybe it was a patient that you were trying to get them to take their medication for their diabetes or for their high blood pressure, and they're not taking it, and you're getting upset because they're not listening to you. They have their own ideas about what they want to do, and that's all that they want to talk about right now, and you're running 30 minutes behind. So you're pretty stressed. Remember how you feel, right? You can feel your heart rate going up, your blood pressure going up, beginning to tense your muscles, your neck muscles, everything does not feel good. There are two things that you can do to control the feelings of stress. And I remember when I went to a exercise where they taught this, they said, I can make sure that you never feel a stressful day in your life. And I thought, well, that's just bogus. That's just ridiculous. How can that be? And I won't say that it totally gets rid of all my stress, but doing these two things, especially the first one, visual field expansion, can really help how I feel when it comes to stressful situations. So I'm going to guide you through this exercise. Imagine you have a visual field this big. As clinicians, we often will look at a patient, they'll tell us they have a sore throat, and we're like zooming into their sore throat, their pharynx. I want to see those red, those white spots on their pharynx and know it's strep, right? Or I've got a lump in my neck, and you immediately want to go touch the neck and feel that lump, right? Well, instead, imagine in this stressful situation, whatever it might be, that you actually allow your visual field to go outwards. So you can't see it because the camera only goes this far, but imagine I'm putting my arms all the way out as if I'm checking visual fields, right? All the way out, and you can see your fingers wiggling way out here. I'm doing this, but way out. You want to see your visual field expand. And as your visual field expands and you're looking really far out in your visual field, and it softens, the whole room will begin to soften, and your pulse rate will begin to decrease, and your blood pressure will decrease, and everything begins to relax. And that's just by virtue of having your visual field expand. So you can actually test this in situations. Try not to do this too often with your spouse or your children, because then they will be saying to you, you're doing that thing with your visual field, stop it. But it is kind of helpful, in stressful situations, whatever those stressful situations might be, to do the visual field expansion. If you're thinking, why is pelvic floor written there? Well, it's actually because the pelvic floor, if you relax the pelvic floor, the same thing happens. You also will shift from sympathetic to parasympathetic dominance, and you'll be able to have your blood pressure, your pulse, and everything relax. Don't relax your pelvic floor right now if you need to go to the restroom, because that would not be a good situation. But thinking about visual field expansion can be helpful, and you may want to take some time to actually practice this with each other. One person pretend to be the clinician or a staff member. You're at the front the front office, right? And the patient comes in and is angry because they want to see the doctor and there's no appointments or whatever it might be. Role play that situation, one person being the patient, one person being the staff member, and seeing how you felt, right? Once you allowed your visual field to relax or you allowed your body to relax, whatever it might be. Very helpful. Obviously, deep breaths. You're not going to go into a downward dog type of yoga pose while you're trying to control your stress, right? But visual field expansion, pelvic floor relaxation can help you in being able to control your stress levels. How do we really find joy in medicine? It's one day at a time. And this was, a phrase by someone, a physician from Grand Rapids, Michigan, really talking about reminding yourself each day of, what brings you joy and what is your mission and what joy did you find today? And part of that helps us remember why we're even here in the first place. So I wanted to share this exercise with you. This is all about recapturing joy and purpose in practice. And I'm going to start digging out some balls here. I have one here. It's a blue one. And I have one here. It's an orange one. And you may say, well, why are you holding all these different color balls? Well, part of it is because I remember watching a movie called Inside Out. And in the movie Inside Out, if you've ever watched this movie, it's a wonderful movie about a young girl who has lots of emotions represented by balls. And the blue ball represented sadness. The orange one represented, what was it represented? Do you remember? The red one definitely was anger. I remember that. The green, disgust. The pink was fear, and I am desperately looking for my yellow ball, which whatever reason I'm still trying to find here. Found my yellow ball. The yellow ball represents joy, right? And so let's think about this exercise. So when you go about your business at work, we can have all these different color balls. And so in this exercise, this game, I'm calling the recapturing joy instead of, capture the flag. It's going to be recapturing joy, the game. And you're going to stand in 2 rows facing each other. And we're going to give you a ball. Each person will get a different color ball. And if it's a yellow ball, we're going to give you an extra ball. Okay, because you have somehow managed to keep joy during your work time, your time at work. And we're going to give you an extra yellow ball to share with someone. And what you're going to do is when the time comes, we're going to tell you to throw your ball at the person opposite you, right? And you're going to hear a question first, and you're going to answer it. So, for example, what is your favorite movie? And say I was answering the question, I would say Big Hero 6, because I love the movie Big Hero 6. And then I would throw my ball at the person across from me. If I have a yellow ball and I'm throwing one of my yellow balls to that person, they're going to catch that yellow ball. And if they were having a blue ball to start with, you would just drop that ball, right? After you've thrown and caught, you're going to take one step to the right. If you receive a yellow ball, you will be given another yellow ball. And if you receive a yellow ball, again, you may discard any other color ball you may have on the floor. Just drop it. And the game ends when everyone has a yellow ball because you've recaptured joy, which is represented by this yellow ball. So I'm going to let you take some time to get into 2 rows. That's right, get into 2 rows. And we're going to have our moderator who's there right now tell you all the questions. And get ready. And after the first question, you're going to start throwing your ball. Okay? I'm going to have you pause the video right now. So you've done this exercise. What did you learn? Well, many of you may say, wow, that actually went much quicker than I expected. When I've done this with other groups of practices, many times they will say, wow, that really went much faster than I thought it was going to be for everybody to get a yellow ball. But what did you need to do to be able to get a yellow ball, right? You needed to capture a ball from somebody else. You needed to be willing to actually throw a ball and capture it, right? And you need to let go of whatever it is that you might have, that you have, whether it be sadness or anger, whatever ball that you might have. And likewise, it's the same with when we're actually doing work every day. We go around doing our work, and you may have come into work with your sad ball or your angry ball or whatever it is that you might have. And we have a choice. And that choice is that we could throw our balls, whatever color balls that we have, at people, or we can choose to maybe accept a yellow ball from someone else if they are particularly chirpy, or maybe we have joy and we want to share it with someone else at work. And before you know it, your culture begins to change and everyone has their little yellow ball. I've been amazed how many people have come up to me at meetings and conferences to say, I still have that yellow ball. I still remember when you taught us that game, right, about recapturing joy, and it's making a difference. So I'm going to encourage you to share this with others, the inspire, create, lead way, right? And share this recapture joy game with those that you love, maybe even your family, those around you, because we do have a choice when it comes to joy, especially when it comes to changing culture. This is a top 10 finding joy in practice, top 10 things to do. And, whether it's one of these things, just pick one thing. I'm not going to read it to you. You can read it yourselves. But I think that it is important, obviously, to have self-care, to make sure that you're sleeping, exercising, eating, and doing the things you love. You want to make sure that you are collaborating and, knowing that your community advocacy can strengthen work engagement and job satisfaction. When was the last time you even had a date night or went on vacation, scheduled a day off? What are the things that drive you crazy? Make sure that you just get rid of those things that drive you crazy. For me, it was at one practice I worked at, it was a poster. I hated that poster. I don't know what it was about the poster. It drove me crazy. So I put a plant in front of the poster. It made me feel good. It's kind of silly, but it made me feel good about being in that situation, in that workplace. If you're in a position where you're able to check in with your team and staff to check for burnout, that's always a good thing. And then building staff morale, discussing grit and ensuring staff safety, allowing time for connection, all of these things that you see in number 10, finding your ikigai, committing to self-compassion. I think a lot of us beat up on ourselves a lot, but it's important to take time to find gratitude and find the work that really is rewarding and steps to whack the work after clinic. I hope you found this helpful. I know that I really enjoyed being able to share this with you. And I wanted to share with you my final closing thought is that we cannot change the world alone. None of us can. But what we can do is to, cast a yellow stone or a yellow ball, right, across the water to create many ripples that affect everyone that we meet and talk and communicate with. And so I hope that as you continue your journey in healthcare, you'll be able to share with each other, share in community, collaboration, and also to create moments of joy for each other to make things better for everyone around you. Take care, everyone. Find your ikigai, and I look forward to seeing you another time. Thank you so much.
Hello. All right, so we're going to talk about an exciting new offering from Blue Cross that you all should have received an email for 2 days ago. So this is what we are calling the Type 2 Diabetes Patient Empowerment Toolkit. And so this is a new benefit that you now are able to prescribe to patients. And so this is a toolkit that will consist of 3 components, the first of which is an Abbott Libre continuous glucose monitor, and it will contain 6 sensors, a total of 6 sensors, and that is it. So keep that in mind, and we'll talk a little bit about what patients this is right for and different possible methods that you can go about getting a CGM for your patients and whether or not this is the one that's right for that patient. It also contains a digital wireless blood pressure monitor and a Bluetooth-enabled weight scale. It is available to commercial PPO patients who have provider-delivered care management or PDCM benefits. And it is available to your patients at no copay to them, regardless as to whether or not they have a pharmacy carve-out or not. So just as a reminder, the use case behind this limited amount of CGMs is really to empower patients and pair with dietary intervention or dietary change. And so just as a reminder, you guys have seen the differences between sensor 1 and sensor 2 when pairing CGM with dietary interventions before, but really empowering those patients to see the effect of blood or effect of their foods on their blood sugars, and then really pairing that with additional remote monitoring technologies such as that blood pressure cuff and the weight scale to really provide them that real-time feedback to pair with their dietary interventions that they are working on with you and your colleagues in the clinic. And so who is eligible to receive this benefit? So like I mentioned on the first slide, they do need to be a commercial PPO beneficiary. They have to be eligible for PDCM benefits, and they have to have type 2 diabetes. Currently, there's no planned end to this. Patients, like I mentioned, will have no copay, regardless as to whether or not their deductible has been met, so that's really important. And the benefit can be prescribed once every 3 years, so this is really meant to be something that enables providers to give patients that initial jump start into making dietary change, to changing their behaviors, and then really get them on a path for behavior modification. And so the way that patients can be identified for whether or not they're PDCM eligible, so just as a quick side note, about 97% of patients with PPO from Blue Cross have that PDCM eligibility. But the way that you can actually make sure is at the end of each month, Blue Cross sends a list to the Michigan Data Collaborative, MDC, and that list then gets sent from MDC along with some additional info on the first Friday of every month out to each PO. So your POs receive this list. On that list, there is a way to filter for patients that have type 2 diabetes, and so you're able to use that list as to determine which patients both have type 2 diabetes and have PDCM benefits, and so you can use that to identify patients that would be qualifying for this. And so just as a quick note, the toolkit is a medical benefit, like I mentioned, so like say, regardless as to whether or not they have a carve-out, they will be able to receive this benefit. And so the other option to checking for whether or not they have PDCM benefits is through the Availity system, so you can do that as well. So who is a good candidate for patients? Who is a good candidate for this toolkit? So this is not necessarily meant to be a replacement for prescribing a CGM through the traditional routes, right? And so if a patient is eligible to receive a CGM through either their medical benefit or their pharmacy benefit, you should continue to do that. So if a patient has Blue Cross Blue Shield pharmacy coverage and is on once daily insulin or whatever coverage specific to their plan is required, you should go through that. So this could be a good idea for patients who do not have pharmacy coverage and also are not on multiple daily injections of insulin, who have not had a CGM in the past. And so that look back will be for 3 years, and so they can't have had a CGM for the last 3 years. It's really meant for patients with type 2 diabetes who would not have otherwise been able to obtain it. And so, like say, as I mentioned, patients that are not on insulin. So who is a good candidate clinically? And so, like I mentioned, we really want to focus this bundle on a jump start for behavior modification and healthy eating. And so the types of patients that we're talking about that may be good to start with at least, that have one of the following criteria. So they have frequent hypoglycemia or hyperglycemia. They have hypoglycemia unawareness. They have significant weight gain in the last year. They have an A1C that's not well controlled. They need medication titration or adjustment, or they need some form of dietary intervention or are planning on doing some form of dietary intervention that this could really benefit and pair nicely with. And so the toolkit has 2 options with 2 sub-options, which we'll talk about. We're going to talk about 3 different wear periods or wear options that you could do with your patient. And this is really meant to be a shared decision making between you as the provider and your patient. And so the first one here is the use case here is wearing a CGM sensor once every 2 months over the course of 12 months, over the course of a year. The delivery schedule for that would look something along the lines of 2 sensors delivered at months 1, 5, and 9. We're still figuring out some of the details with that. If shelf life allows, we may ship them in just 2 shipments or maybe even 1 shipment, depending on shelf life of the individual sensors. And the use case really for that is providing intermittent reinforcement of dietary changes over a longer span of time, really providing that full year of feedback, change, and feedback over and over. The second use case here is continuous wear. You may have patients that you think would benefit from a more intensive, shorter-term dietary counseling class or group activity, and you could have them wear a CGM continuously. Those 6 sensors that are good for 2 weeks each would cover a total of 3 months if worn continuously. And so that would be all 6 sensors being delivered all together at the very beginning at month 0. And then that use case is really either for the adjustment of medications or for if the patient's enrolled in like a diabetes education class or dietary change class, it's going to be more intensive right all at once. And then the third final option here is another prolonged but slightly less long, so it's over the course of 6 months rather than 12 months. And so this would be to wear 1 sensor for a month, 1 month off, and then 1 month on. So this is really trying to use an initial sensor to identify dietary challenges where the patients are struggling, what kind of things you as the clinician or the provider want to work on, and then what changes need to be made, and then subsequent sensors to either evaluate whether or not those changes are being successful or to be able to perform PDSA cycles with that patient and make further adjustments. And so this is what the prescription order form looks like. As I mentioned, there are 3 real options. You'll notice in the first option here, that's the continuous wear option on the script here, and then option 2 has frequency, and there's 2 sub-check boxes, so this is what that's going to look like. So first option will, for the time being, enable the use of the Freestyle Libre 3 because the DME supplier will be able to use the supply that they have for that, but due to some supply chain issues, the option 2, which includes both the 6-month and the 12-month wear options, will most likely, for the time being, utilize the Freestyle Libre 2 system. All right, so some future data opportunities. So as a part of this 3-in-1 bundle, we really want to empower not only patients, but you as the providers to utilize some of this to get the data back from JMB, the Toolkit provider, and feed it back either into our dashboards or into PO level reports that we've provided to you guys. And so this is something that we're working on developing so that we can really leverage the data received, both the CGM metrics as well as the Toolkit and blood pressure metrics, that we can put into usable, really important reports for you as the PO and providers. And then so we'll have a couple more information coming soon, but the launch will be on November 17th, and we'll be sharing specific instructions with you and providing you with tools and additional support on how to operationalize this once we get closer to and even after the Toolkit goes live. All right, so any questions on the Patient Empowerment Toolkit? We do have the blood pressure cuff and both the Libre 2 and Libre 3 CGM on the coffee table in the back of the room if you would like to check that out. I'm sure you've all seen a CGM at this point, but you can at least check out what the Libre 3 looks like if you haven't seen that yet, and what the blood pressure cuff looks like at this point. Questions on the Patient Empowerment Toolkit? Yes, Dr. Gavison. This is only for Blue Cross Blue Shield PPO patients with PDCM benefits. Yes, at 0. Premier Care is PPO, right? Is it BCN? Premier Care is BCN, then no. Mm-hmm. Pick what? Pick which patients to prescribe to? Yeah, it's available to all of your patients that meet that eligibility. We provide guidelines as to who it may be best for. Like, say, if you have a patient that is PPO and does not have a carb out and can get a script through their pharmacy benefit continuously, that would probably be a better option for that patient, but it's at you, the provider's discretion. Yep. Yes?
It would allow you to do RPM, which means patient reporting. remote patient monitoring, thank you. If the patient has that benefit, they could use it to then submit the data straight to you, but it's going to be reliant on your EMR to get the patient monitoring information. Any other questions? That's a great question. We will look more into that. It's an important point that we can educate about in terms of billing. This is new, and we're very, very excited about it. Implementing a new program like this is going to be some work, and we recognize that, and we're here to support you in doing that. Again, it's a pilot. We're so grateful that Blue Cross Blue Shield is doing this, and we're excited to see how it helps your patients. So we'll be looking along the way to get data back from you about usability, how easy it was to do, and then if it benefited your patients. All right, I'm going to move on to a couple more updates, and then we are almost out of time. So I just want to let you know a little bit more about our patient advisory board. At MCT2D, we really strive to put the voice of the patient right front and center of the collaborative, and that means that we have brought together a patient advisory board that meets every other month to review our tools, give their feedback, give us ideas for new tools, and make sure that in general the collaborative is benefiting what they think is most important. We are recruiting new patient advisors for two reasons. Number one, some people move and then they leave the advisory panel, and we want to make sure we broaden and diversify our voices. And that means for me, rural and urban patients, southern and northern Michigan, patients with different racial and ethnic backgrounds, and patients with different insurance coverage and needs, patients with different disabilities. And so there is a handout in your packet that you can find, and then there are flyers on the back table. What we really appreciate about our patient advisors is that we had them present at our collaborative-wide meeting. One of Heidi's patients presented on their journey on using a CGM, and it was a wonderful presentation from the patient's point of view. They helped us review and revise 7 tools. They've recorded patient testimonials to share on our website and feedback about our mission, vision, and values. We have a couple of different additional requirements in addition to our provider organization level VBR for each clinician, physician. And so if you recommend a patient to the advisory board, that provides you a credit for part of your VBR as a clinician. So these handouts are at the back table. So I want you to think, is there a person you take care of with diabetes who would be so excited to share their experience and be able to shape this collaborative? If you can keep that person in mind and get a flyer to them, we would be so, so appreciative. We want to have as many patients involved as possible. We see our patients as advisors and consultants. We pay them for our time. They get $25 for every virtual meeting that they attend. So we really appreciate your help in that. Learning community events, this is really where I'm going to ask for your feedback in writing. We tried this with a poll on cell phones. It did not work last night. So if you open your folder, there will be a handout that asks for your feedback about what kind of learning community events you would like us to do next year. I think this might be easier on paper, so if you don't mind writing it down, I can give pens to anyone who lost theirs with the ball exercise. This is what we did last year, and so we don't want to repeat topics. We learned about CKD management, low-carb diets, cardiology and type 2 diabetes, implementing our initiatives. We had one of our metabolic surgeons present and talked about multidisciplinary teams. Dr. Gabison, thank you for talking about patient motivation last month. Dr. Dina Grausda is going to talk about weight loss medications and an update in November. And Dr. Kara Mizukami-Stout and Jake Reese are going to talk about navigating CGMs in December. For the next 6 to 12 months, could you please write down any ideas you have for a learning collaborative community event? And we would love to use that to generate ideas from you for what we're going to put together for next year. You know, if you want a deeper dive or a specific part of one of these topics, please write that down as well. What you will also see on that piece of paper, as I hand it over to Rena to talk about some low-carb diet tool updates, is a request for you to tell us which other dietary foodways you might want us to develop a food plan for. And then the last question is about point-of-care A1C tests. So at this point, I'm going to ask you to just give us your feedback about each of those for just a few minutes. If you have no ideas, that's fine. We will come up with suggestions. And then I want to remind you that all of these events are taped, and they're all on YouTube, free and available. If you want to share them with anyone in your practice, I review them regularly. They're such good sources of information. So as I thank you so much for giving us your feedback, I'm going to have you hand those back to the checkout table as you leave. And as I turn it over to Rena, I'm also going to remind you that there is a feedback form for this event. So please give us your feedback before you leave so we can make these events better for you and turn that in on the way out. So Rena, I'm going to turn it over to you.
Thank you, Dr. Oshman. Oh, perfect. Hi, everybody. I'm Rena. I'm the dietitian working with MCT2D. I just wanted to share some exciting updates that we've been working on this year related to the low carb initiative. So we've been working diligently to make some updates to the low carb food tracker as well as the low carb cheat sheet that's available now on the MCT2D website. We've also been creating some 2023 updates to the low carb jumpstart packet for folks who are, for your patients who might be interested to wanting to learn a little bit more about how to start and adapt a low carbohydrate lifestyle. So these are currently sort of in the works, and we're excited to be sharing this with you soon. Oops, there we go. Okay, so one of the new tools that we're very thrilled to share with you today is a brand new tool that we call Celebrating Cultural Diversity. And this is essentially in response to the feedback that we received from you all in the collaborative in terms of creating a cultural meal plan that is adapted to meet the needs of the patient populations that you work with. And as we know, we have a very diverse populations that we work with here in Michigan that we serve. And so, you know, even though we understand that we're only really skimming just the mere surface of the cultural diversity of foods and cultural traditions, we wanted to create some low-carb adaptations to some of the diverse regional and cultural foods that we have around the globe. So, our wonderful multimedia designer, Julian, worked really hard together to collaborate on creating this booklet that we have available for you all to take home with you today. That's at the back of this room. So we're really excited. We kind of traveled across different regions throughout the world to share some of those common ingredients that are used in different cultural cuisines and how, and we provided some ideas and inspirations for how to adapt meals to more to suit the low carbohydrate lifestyle. In addition, just as a reminder, we did also work on, we're continuing to expand on the sample meal plans, and most recently we've created the Lacto-Ovo-Vegetarian 7-day sample meal plan that's available for you all to take home as well. And another exciting update that I wanted to share, so we have been working together earlier this year to collaborate with local community or local communities, and starting off with a Detroit local restaurant called Breadless. And so the Breadless is focused on healthy eating, to make healthy eating accessible for all, for everyone in the community, and they really focus on healthy, delicious and tasty food that also happens to be low carb, and also other dietary, or for folks who have other dietary restrictions. So we were able to do a collaboration and continuing to work together with them to release some exciting collaborations, including a couple of collab items, menu items that we worked together to share with everybody here in the community and for the patients that you work with. So we came up with 2 menu items that you can see here. One is the BLT2D, and You Take My Bread Away. And this was a really fun contest that we did with the team members to come up with creative names. And you'll see too that they, at the restaurant, they have a lot of, they have some catchy names for their menu items. Coming out of this collaboration, we have some exciting blog posts that we wanted to share, that we will be sharing with the collaborative. It's going to be 2 parts. The first part that's released now in the Jumpstart website, and we also have a recipe that we share For anyone who wants to try to make a breadless sandwich using dark leafy greens as the alternative. And we also had the opportunity to go to the restaurant with a patient advisory board member, Frankie, to record a video demonstration of how to make the items that you see here. So that video is in the process of being released soon for everyone in the collaborative to see. So we're really excited about that. And last but not least, we do have a coupon code. Since you all are in Washtenaw area, hopefully if you are also in the Detroit metro area and want to check out the restaurant, we do have a coupon code that you can use to get $2 off your order. All right. Thank you.
Thank you so much, Rena. This is really fun for the team. I'm going to pass it along to Julian to talk about our website update.
Thank you. Thank you. Yeah, so the MCT2D design and informatics team went through a process of updating the website. Our actual web developer is back in the center table, Ryan Karpus. Definitely want to make sure I showcase him. I know he loves that. So, yeah, new design, improved navigation, and the the homepage is really meant to be sort of a snapshot, a showcase of the most relevant resources and news and events for people visiting the site. So one of the biggest improvements made to the website is our navigation. We wanted to make this, well, we wanted to showcase a couple things. First, that we now have a new health equity page to make sure that, or to show that where health equity is becoming a real important part, a foundational part in the way that we're doing the work here at MCT2D. And that we're shifting the focus from just primary care to some of the specialty care, so nephrology and endocrinology have their own pages. Let's see. So the resource library has had a huge facelift and has been revamped to make it easier for you to find resources. So we want you to be able to save your resources, be able to get to them quickly, and to share them with patients and colleagues. Let's see. So new filtering system, and one of the things that we're really excited about are these curated collections that you'll be able to actually look for resources that sort of meet this theme and that we found that members have found very valuable. Okay, a really big update is the members dashboard. So the members dashboard is really unique, where as a member you'll be able to go into it and quickly find and view your VBR requirements, see upcoming events that pertain to you and your specific role, see news and more based on your role in the PO, your PO's quality initiative focus. So, for instance, a user might have, primary care, or their role might be a primary care provider, and with the focus of CGM, and the page will actually populate the relevant VBR requirements and ways to fulfill those requirements. And if you want to actually track how you are doing on your VBR requirements and where you are with them, if you log into the admin portal, you'll be able to actually track how that's going. The events page has been updated to allow for new filtering and multiple view options, so you'll be able to view it with like a detailed view, a list, and by month. And the patients page, which I think is a really good resource for, especially if you're going to refer patients to MCT2D's resources. It promotes the patient advisory board. It will showcase a lot of great resources that are patient-facing, and it allows patients to opt in to share their CGM data with the MCT2D. So if you You can actually sign up for a feedback session with me or someone else on the design team to give us feedback on the website. It'll just be a 15-minute one-on-one Zoom call, and it fulfills your primary care practice level VBR. So if you really want to hang out with me and talk to me and have like a nice discussion about how you feel about the website, please do sign up. Thank you.
Round of applause for the design team. I think hopefully you notice our stuff looks good, including these stickers that you can give to your kids or keep and put on your computer, swag bags. Making tools that are beautiful and fun to use for our patients is really important to us. The last thing that I want to share before I let you go is that we want to empower each of you to go back to your practice and educate and share with the rest of the clinicians and team members involved in diabetes care what you learned today. And so the last handout in your packet is our regional meeting highlights. There are QR codes that go to each of our different resources that we talked about today, and like a top 10 list of the things that we think that you might want to share. If you want more help with creating a PowerPoint or another way to share this with your practices, some physician organizations are doing that as a group, some practices are doing that individually. Happy to share any information you need to make sure that everybody gets the information that they need at your practice. So last things last, I'm going to pick up the suggestions for future learning community events and the evaluation for today. If you didn't already fill it out, please do. We continue to try to make these meetings more helpful and fun, and I hope everyone had a little bit of fun. So drive safe. Thank you so much. And if anyone has questions, I can take them. You can stay after, but appreciate you so much. Take care.